Central lumbar disc prolapse. This is really very important indeed, but not commonly diagnosed. Now there's a scan, and you can see on that scan the red arrow is pointing at a central lumbar disc prolapse.
Could you, apologies for interrupting your flow here, many people won't be quite as familiar with MR imagery as perhaps you are. Would you mind just taking us through a few of the structures on there so people can just identify what they're looking at?
Yeah.
You might be better off using the pointer, because then we can have it up at full screen for them.
Okay. Here, whoops. That's it.
Right.
There you can see the disc bulging back towards the spinous process.
Right. So the big round circle of dark material, that is the intervertebral disc, and then there's a little bit poking out from it, which is the
where
prolapse.
the arrow is going.
And the bright signal below that.
Yeah, well then you've got facet joints either side.
Yep. Those are the dark spaces between the lighter signals.
And you also got the lateral recesses, so that if that disc was prolapsing left or right, you would end up with your sciatica left or right. But here, there is no sciatica.
Right.
There is no major leg pain. There's certainly no differential diagnosis from a neurological testing point of view. Reflexes are fine, power's fine, sensory's fine, but it comes back to all of the possible reasons which come from your history.
Yes.
It's a weight-bearing problem. There's only two structures in the spine that carry weight: discs and bones.
Yep.
Anything else carries weight, it wears out, and then now you've got spondyloarthrosis. So that's the problem. It's a weight-bearing problem. So therefore it's going to be worse in the morning. Now, standard medical school education says morning pain is inflammatory, as in, for example, ankylosing spondylitis.
Yes.
But the disc is a sponge. You're horizontal on that disc when you're in bed, and when you become vertical on that disc, you compress it. So therefore, first 20 minutes, disc pain is always going to be very uncomfortable, and then it wears off.
Yeah.
I tell my disc patients, leave your shoes and socks by the front door, put them on just before you're going to go out, and it's much easier to bend.
Yeah.
Things like coughing, sneezing, which provoke that bulge, whereas movement tends to make discs easier. Now, if you've got a coccyx, all those questions will be fairly negative. But if it's a weight-bearing problem, can you sit on the coccyx? And most people say, well, I always sit on one buttock. Mm-hmm. Okay, that's a clear example of avoiding the coccyx. And things like getting out of a chair. As you rise and get out of a chair with a disc lesion, you've got to go back into extension, trapping the bulging prolapse. Coccyx, not a problem. Right. Things like potholes in the road. A patient once said to me, you should have your telephone number printed backwards over potholes. So once you hit the pothole, look up, Sandler, Osteopathic. Right. We didn't bother. But the jolting, the jarring, but very specifically, so coccygeal pain, if it's a traumatic coccyx, we'll be looking at that. But as I said before, you've got to take a full medical history, because anything that's gynecological, associated with the colorectal area or with the prostate area, these can all produce phantom pains because the nerve supply is common to all of them.